My name is Giselle. I'm the nurse practitioner here at the Pacific Movement Disorder Center. Welcome to our Everything Parkinson's webinar. We're grateful for everyone that joins us every month. Today, before we start, I just wanted to announce that the previous seminars are already now online. You can view them at our website at the Pacific Movement org. You go to patient support and then click that, and you will see webinars, and the previous webinar will be there. So I'm gonna jump right in. We do have a very special guest today. He is our director for restorative neurosurgery and deep brain stimulation program here at the Pacific Movement Disorder Center at Providence St. John's, and likewise at the Providence Little Company of Mary Medical Center. He does have a lot of experience with DBS. He is a board certified and fellowship trained neurosurgeon that specializes in the neurological treatment of movement disorders, epilepsy, and psychiatric conditions. He has had experience using neuromodulation to treat conditions such as Parkinson's, essential tremor, dystonia, epilepsy, and obsessive compulsive disorder. He has also had very special interest in research. He is the principal investigator of uh, multiple clinical trials, one of which uses DBS to treat post-traumatic stress disorders for combat veterans. He also is the principal investigator of a clinical trial evaluating non-invasive trigeminal nerve stimulation as a potential treatment for chronic post-concussive syndrome. So he definitely brings several years of experience. It is an honor to have him speak to us today about deep brain stimulation. Please all welcome Dr. John Philippe Langevin. You're
Thanks, Giselle.
unmuted.
Thanks, Giselle, for the introduction. And I just need permission to share my screen when you have a second.
I put you as panelist, Dr. Langevin, so you should be able to.
Okay. All right. It's still showing me as disable screen sharing.
Let me just. Okay, I made you a host, co-host.
Very good.
See if you're be able to. Okay.
Yeah, that works. Let me just share my screen now. And I'm going to go on presentation mode. All right, so we see the slides okay? Giselle, you see the slides okay?
Yes, yes, we do. Thank you, Dr. J.
Yeah, thank you, Giselle. Thanks, Dr. Petrosian, Dr. Diaz, for inviting me to discuss this seminar today. The goal of the presentation is just to introduce deep brain stimulation, so the surgery that we can perform to help out with Parkinson's disease and essential tremor. Um, And basically, the agenda of the talk is just to go over who should be considering DBS, like at what stage, what kind of symptoms is it going to help you out, and then what can be reasonably expected from DBS. So a lot of the success of the surgery is proper selection, in terms of like which symptoms are going to be helped by DBS, and also making sure that everybody's on the same page with expectations from the surgery. So it's a big step to have the surgery. We want to make sure that no one has expectations where symptoms would not be improved, after the procedure. And then I wanted to discuss how we perform the surgery here at St. John's and the Providence system. So first of all, so when should we, should DBS be considered for patients who've been suffering from Parkinson's disease. First of all, we prefer when patients have had Parkinson's disease for a few years at least, so like, anywhere between 3 to 5 years, to make sure that the diagnosis has been well established and that it's not something where it's rapidly progressive. But from the patient's perspective, our patients who do the best after surgery tends to be the one who, when they came in, had too much off time. So those are people who felt great when the medication was on and they were able to do their activities and they didn't have any problems. But then the problem is that they run out basically of the efficacy of the medication pretty quickly, and then they have to wait until the next dose sort of kicks in. So they are in a situation taking Sinemet every 2 to 3 hours, for example, and they're afraid to venture out of the house too much because the symptoms of Parkinson's disease can hit relatively erratically, and so they don't want to be frozen, let's say at a shopping mall or while performing their hobbies. The other patients who tend to improve a lot after DBS are the ones who have reasonable response to Sinemet and L-DOPA, but they have too much side effects from the medication. And so in those patients, it could be like psychiatric side effects, like psychological side effects, or physiological side effects. But so for a reason or another, they are limited into how much medication they can use because of the medication side effects. And so for those patients, DBS might be useful because the DBS may allow to act in synergy with the medication that can be used. And so the dosage can be reduced and the frequency can be reduced. Other symptoms that are improved in excess to what people experience with the medication is tremor. So in general, tremor improve with DBS more than what you would have with just a medication. So it's one of those symptoms that goes beyond what you experience with the meds. And dyskinesia is another one that can be specifically targeted with DBS. And so sometimes the efficacy of DBS can be in excess to what people experience with just a medication. So those two symptoms are kind of like a special category that does really well with DBS. And finally, I put this here, thinking about stopping hobbies and jobs, because what we've noticed is that if we wait too long for patients to consider to have DBS, because we feel like it's a last resort type of thing, then people have stopped working or stopped their hobbies. And in that situation, it's very hard to get somebody back into the activities that they enjoy once it's stopped. So what the studies have shown is that it's better to do the DBS prior to stopping any activities, so that the therapy can maintain people performing their activities, and it keeps them there longer. And so as a result of that, the studies have shown that the quality of life is improved in that scenario. Whereas if you stop, even if we have the DBS and you have similar benefits, there's really a lot of inertia where it's really hard to resume activities that have been stopped for a while. And basically what to expect. So for those people who've had DBS, or what are their limitations? So oftentimes, people come to us feeling that once a device or an implantable device is placed in, then the life is changed dramatically afterwards. And actually, most of the time, it's not the case. The purpose of the device is to so that the patients can resume their life and go by their activities. So we don't want to place an handcuff, so to speak, that after the device is in, you have to be aware and very careful of any activities that you're doing. And so, essentially there's the small pulse generator that's inserted in the upper chest area. The electrodes are inserted in the brain. And in general, there's no activity restrictions after the placement of the DBS, so that we want the patients to resume all their sports, all of their hobbies. And so we've had patients, for example, who enjoyed playing tennis, so there's a lot of activities at the shoulder level, neck area moving. And so we just want to make sure when we place a device that it's not going to, create any feeling or that the patient feels restricted in any way. But basically, the patient should not be concerned that the device is fragile and that it's going to break or snap with those activities. So the implant is built in such a way, the engineering is in such a way that it's going to tolerate a lot of activity, a lot of movement, and so we do want the patients to resume all their activities. So there's no restrictions. Some of the consideration is that we may place the device on the left side versus the right side, depending on your activity. So we had patients who are doing a lot of bowling, or again, a lot of tennis, or they enjoy, using rifles. And so we want to make sure we know that ahead of time. We purposefully ask those questions in the clinic prior, so that we will place the device on the side where there is perhaps less movement. Not because the movement would damage the device again, but we just want to make sure we're not limiting in any way the motion or the activity that is to be performed. In terms of the battery maintenance, so again, it's a situation where we want to make sure that you can go by to your doing your activities and going by in your life without having to have an anchor, that we're implanting in. And there's essentially two types of battery. There's some that are rechargeable and some that are non-rechargeable. The rechargeable one requires to have like to be charged every other day on average. And it's something that takes about 20 minutes, where the patients place a wand or an antenna on top of the battery, and it's charged non-invasively. So there's nothing that pokes through the skin or anything like that. You do have to remember, though, to charge the device. Otherwise, if the battery runs out, then you're not going to have the therapy until it's charged up again. The nice thing with the non-rechargeable is that you don't have to think about recharging it, but then you do have to have it replaced. In general, it's every 3 to 5 years. The replacement is a small procedure that's done under local anesthesia with the patients under partial sedation, so it's kind of twilight, but not fully asleep. So it's not a big surgery, but it's something that you have to undergo with a non-rechargeable. The device maker have made a lot of improvement over the last 5 to 10 years, and now all the batteries that are commercially available have clearance for MRIs. So patients who have other conditions, it could be arthritis, where they need an occasional MRI, or perhaps a lesion or a tumor that needs to be followed with MRI. So it used to be a problem, having DBS in that sense. But nowadays, all those devices have MRI compatibility clearance from the FDA. So you receive a pocket card that you keep in your wallet after the surgery. And so the technologist of the MRI will ask you before performing the MRI if you have any implant. And so once you disclose the type of implant that you have, they adjust the MRI sequence that are to be performed so that it can be completed safely. And finally, we get a fair amount of questions about flying and going through metal detectors. And it used to be that the first generations of the device were pretty susceptible with what we call electromagnetic interference, meaning, when you go through a metal detector. And what it used to do is occasionally the device would shut itself off, so that the patients had to restart the system, with their remote programmer. Nowadays, the devices have been shielded much more efficiently inside their own coverage. And so we haven't really seen any problems with people going through metal detector where they feel, any different than, they're not going through the detectors. So it hasn't been an issue anymore. And in terms of flying, the TSA agents are pretty well aware of those implantable devices, since they're the similar technology than the cardiac pacemaker, which are pretty widespread in the society. And so once you tell them that you have an implanted device, they ask you to show you where the device is located in your body, like the battery pack. and then they use their paddle wand instead of having you throw the machine, and that's how so you're not limited into flying. And so this video shows, what can be expected after the implantation of a, DBS device. And so this lady has classic Parkinson's disease, and the traditional symptoms of bradykinesia, so like slowness of movement, rigidity, and a little bit of tremor. And so you can see that she has a lot of difficulty, getting out of the car initially using a cane. And this is the same patient, once the surgery has been completed and the battery, the DBS therapy has been started. And so we can see the movements are a lot more fluid, and walking with more ease as a result of that. And so in essence, any symptoms that is improved with Sinemet or L-DOPA is expected to also get better with the DBS. And we have also an example with for the tremor. So I mentioned how with tremor, the improvement can be in excess of what you get with the medication. So this patient has essential tremor. And I'm going to try to synchronize here the videos. But essentially, the patient is asked to turn the DBS off on the left side of the screen. And on the same day, the same patient is then performing the same activity with the DBS on. And so you can see how, like with just stimulation, in this case without any medication, how there's a big difference in what can be accomplished. And so it's very simple task in terms of signing check, completing paperwork, things that are basic but essential in everyday life. And so that's how the DBS can really affect that. So I can just pause here the video once we see the, sorry, I'm just going to go back. Trying to advance the. And oftentimes the patient will tell us that they can't remember the last time that they saw, their signatures done properly, basically, and they're amazed on how after the stimulation is completed, they can have a legible signature. And on this final task, we're just asking the patient to transfer a cup of water, from one cup to the other, and essentially just mimicking how difficult it is sometimes to drink from a cup with severe tremor. And so with the DBS, there's still maybe a 5%, 10% of tremor, but the movement becomes functional so that the patient can resume drinking properly from a cup. And basically the slide just shows, some testament from our patients who send us pictures, and in this case here, video, where, as I mentioned from a prior slide, we want the patients to resume their hobbies. And so for the patient on the left, he was still able to ski just on the medication with Parkinson's disease, but receiving a Sinemet. However, because of the off time, he was afraid to venture off on the slope, because, you don't want to be experiencing freezing while you're on the top of the hill. And so the DBS gave him the extra confidence to resume that activity because he felt like he had continuous control over his symptoms with the stimulation on. And similar on the right side, this patient enjoyed riding the waves, with surfing. And that's something else where, you don't necessarily want to be in the water if you're experiencing a lot of Parkinson's symptoms. And again, the DBS is not providing an excess amount of benefit in terms of the motor movement, but it's just keeping you at the optimal control for a longer period of time during the day. So since you can eliminate those off time, you can safely resume a lot of activities in your life. And you were showing some more extreme cases, but for most people, it means they can go back shopping because they're not afraid that they're going to be freezing at the mall or at the grocery store, for example. I mentioned earlier that the device makers have made an increasing amount of improvement over the last 5 years. Um, and the major driver behind that is because now there's a lot more competition amongst the device makers. So there's currently 3 devices that are FDA approved in the United States for us to use in the treatment of Parkinson's disease. And each device maker is now competing against each other. And so it's leading to benefit from the patients because they are trying to hedge each other off in terms of like the better technology. The first player in the world of DBS was Medtronic, which received the approval in 1997. Medtronic was the only player in that sphere for many years. But recently they've done a huge amount of improvement. And so I'm showing here this new device that's called Percept. And the paradigm shift now is that instead of just having a device that stimulates or sends the small, electrical activity that we call the deep brain stimulation continuously, this device is also recording the activity inside the brain chronically. And this may look trivial, right? So what are we going to do with that information, like those brain activities? So we're seeing the neurons, talking to each other with this device. And from month to month, when you see your provider, they can interrogate a device and, so to speak, download that data and look at it. It turns out that there is years of research now showing that there is a specific frequency of activity inside the brain that when it's showing a lot of activity or high activity, it is correlated with periods of time when your symptoms are poorly controlled. So it seems that we're having a marker now, so to speak, like a biomarker, where we can look back and say like, well, perhaps the tremor control or the Parkinson's disease control was not optimal this past month. So your physician can still ask you, how you've been doing in the past month, what has been working, what has not been working. In this case, from the DBS programming, the adjustments that were made, as well as the medication the medication adjustments that were made. And obviously, you'll be able to tell your providers. Sometimes a loved one will accompany you, and they'll be able to keep a diary, so to speak, saying like, okay, these days of the month were good, other things work well, these things did not work as well. But sometimes it's hard, to remember everything and to keep track. And, you may feel like you're going home and you forgot a lot of this stuff, like, so I forgot to mention that, sometimes I'm having problems like at this time during the day. So this is an added benefit here where in the future, we believe that DAS marker is going to be providing the neurologists a tremendous amount of information where they can look back month to month and look whether or not we're making headways. So like the adjustments in DBS, is it reducing that biomarker? Are we driving it down, or are we stalled somewhere? And the other thing that it provides is not just month to month, but within every day we can home in on the areas of the days that are more problematic. So perhaps the marker is much higher early in the morning, or it could be late at night. And so those are areas of opportunity to perhaps make the small tweak in medication during these times of the day to optimize the control that you have. We think that eventually where the technology is going to be going, we're not there yet, but the device is going to be able to sense that the marker is not being treated appropriately. So to speak, like read your symptoms and make adjustment in of itself. So we're not there yet, but we think that in a few years, the computer is going to be able to auto adjust the stimulation to optimize the treatment. Just 2 weeks ago, the Medtronic came out with a new electrode that is slightly different, and I have another slide on that. But just to mention that the technology is continuously improving. Another company is Abbott, Abbott Medical, another American company that has a very similar device. This time, the patients always receive a programmer that you get home. With the Medtronic system, it's a Samsung, essentially device that you get to help you programming and interrogating your device. with the Abbott system, they use the Apple product, so you get basically an equivalent of an iPhone, so you can make calls with it, but you can interrogate your device. It tells you, for example, if your battery is working properly and how much energy is left into your device. So you can get a lot of information. And once you're trained and you know how to use it, you can even make some slight adjustment on your own within a window that's pre-programmed at your physician. So if you feel like you need a little bit more or a little bit less energy, so it's a change that you can make yourself. And the last device maker is Boston Scientific. Boston has a excellent rechargeable device that lasts in excess of 15, 20 years without limit. So depending on how much energy you use. And all three companies now have so-called what we call directional current. And I put this slide here to show you what that is, because if you elect to have DBS therapy, from now into the future, most likely your physician is going to be discussing so-called directional current. And so just so you can put a mental image of what that could be. So imagine you have, this representation of a brain, and the electrodes are located in that precise spot inside the brain. And what we've done, so far since 1997 with DBS is this image that you see on the right, where you have the electrode inside the target with a perfect circle around it. So that blue circle is the electrical current. So that's being delivered to that exact target. But imagine that, like, if we increase that current, higher, it's a little bit like a medication dosage. At some point, we reach a point where we're starting to have side effects, from a high dose. And with DBS, part of the reason why we're having side effect is because some of the electrical activity is starting to encroach on other areas of the brain. So in this case, it's going too far to the right. So like the circle is getting too big and it's not staying contained inside that small region. So what directional leads are doing is that they allow the physician to shape that electrical current in non-spherical ways, so that it doesn't need to look like a circle anymore. So we can have an oval, or we can be skewed completely on one side. And it may look like it's a trivial change, but it allows for two things. It allows us to, first of all, focus the electrical current where it needs to go, like the specific area of the brain where it needs to be stimulated. And the second thing that it allows us to use less energy globally. So since we're not wasting a lot of energy in stimulating areas of the brain that don't need to be stimulated, we can really focus all the current in the hot spot, like the red zone, so to speak. So we can use a smaller amount of current because it's all being delivered where it really needs to go. So that means that we are asking less of the battery. So if you have a non-rechargeable battery, it may last longer. If you have a rechargeable battery, you may need to charge it less often. So in a nutshell, we think that directional current is important. It's going to be here to stay. Most of the devices that are going to be implanted from now on are going to have directionality in their current. And the advantage is that we can achieve even better control over the symptoms, and without side effects, with less side effects, and we can preserve batteries for a longer period of time. So basically two benefits. And the way it's doing that, so just for people who are curious, historically, the top electrode that you see there, that's the model that it was in existence since the mid-90s, where you have 4 rings. We can stimulate any of those rings, but they're perfectly completed rings, basically, around the electrodes. And what they've done now, the engineers of the company, it's that lower electrode, the second one at the bottom, where the 2 middle rings have been broken down into 3 subunits. So they're not complete rings, they're like 3 parcels. And so now you can select to use current only on one of those subunits. So that's how basically we can shape the current to match the anatomy and only stimulate the precise spot inside the brain where we need to go. The symptoms that are not improved now, so we discussed the symptoms, that do get better with Parkinson's disease, just to go over that one more time. All the symptoms that are improved with L-DOPA or Sinemet are also going to be improved with DBS. And the two additional symptoms that are improved in excess to what you experience with L-DOPA are dyskinesia and tremor control. Now, for the things that don't get better with DBS, it's basically symptoms that tend to occur like in the center of the body, like the midline symptoms. So the difficulty with swallowing, droopy eyelids that may occur occasionally with advanced Parkinson's disease, problems with cognition. So sometimes people have problems with memories, attention problems. It could be related to Parkinson or other conditions. Those symptoms are not going to get better or improve with the DBS. And so occasionally we have to be careful, ahead of the surgery. If somebody has a lot of problems with cognition, we want to be careful about placing a DBS, because it could be more difficult for the caretaker to take care of the patient if they have a lot of cognitive problems, and now they're able to walk more and get into trouble more readily. So those are the issues for which everybody will undergo neuropsychological testing prior to undergoing DBS, not to disqualify patients, so to speak, but at least so that the providers and the family members and the patients themselves are aware of potential challenge or things to watch for after the surgery. Other things that tend to not improve is poor balance or falls. And finally, gait freezing tends to be multifactorial, meaning that many things are entering into play. Some symptoms might be improved if the gait freezing is related, let's say, to rigidity, like stiffness or bradykinesia, so that would improve. But on other times, unfortunately, the gait freezing does not improve despite DBS. And so it's important to have a thorough evaluation with your neurologist and a neurosurgeon prior to the surgery, and understanding which symptoms are truly driving the problems in your life and reduction in quality of life, and seeing if those symptoms are going to be improved or not with the DBS. And so the patients who are really happy with DBS are the ones where the symptoms, obviously, that caused them a reduction in their quality of life were the ones that were a home run with DBS and get a lot better. Discussing our approach to DBS surgery. So for those patients who then will, are selected and decide to undergo surgery, the way we perform the procedure at Providence is a little different than most of the other institutions. And we really focus on, these four pillars, at our centers. We want to first make the surgery as comfortable as possible and recovery as fast as possible. So look, we're really focused on minimally invasive approach, meaning smaller incisions and less restraints, less reliance on anesthesia. So trying to make the surgery less demanding on the body so that the patients can recover faster. Obviously, we have a full focus on safety, so to make sure that we reduce the complication rate as low as possible. And that goes from the big things like, bleeding or issues like that, or to the more minor complications like infections, trying to avoid any problems that can arise from the surgery. Our third focus is to make sure that our patients will experience symptoms improvement. And in there, we focus on, obviously, like precision at the time of the surgery to make sure that our surgeries are performed where the electrodes are exactly where we need them to go, but also that we select the proper target based on the symptoms of the patients, that we select the proper symptoms to target, the proper patients to undergo the surgery. And now that we also select the proper device for each patient. And all those decisions along the way are made between the multidisciplinary team that includes our neurologists, myself, our neuropsychologist who evaluates the patient, and our nurse practitioner Giselle. And so we all have multidisciplinary meetings on a monthly basis where we discuss every single case and specifically and try to make those decisions on a case-by-case basis where the device, the target, the specific hardware that we select, everything is lined up so that we focus on symptom improvement. And finally, as I mentioned, we work with our allies in the hospital, the nursing staff, the physical therapists to ensure that the patients are comfortable and that they are encouraged to ambulate, resume their life as soon as possible so that they can return to home and to their life as quickly as possible after the procedure. And so these are some of the steps. One of the steps that we focused on was to let go of the large classic stereotactic frames. So you may have seen videos or pictures where patients are wearing a large frame around the head, where the head is fixated to the bed. And so in an effort to reduce the length of the surgery and to reduce the amount of immobilization of the head during the procedure, we are using a frameless device without compromising the accuracy of the targeting, without so that the electrodes are on target without having to use a large frame. And so what we do is about a week to 2 weeks prior to the surgery, the patients come into our clinic, and then under local anesthesia, we place tiny markers on the skull. And so basically, essentially in our chair, almost like a dental chair, and then we make a tiny opening in the scalp with local, numbing medication, and we have a marker that looks like a tiny screw, basically that's fixated to the area, and there's one suture that closes the skin at every of the spot. And so this allows us to basically plan the entire surgery while the patient is at home. So then we have MRIs. We now have a CT scan with 4 markers that are acting as a reference. And we can plan the entire surgery, so to avoid any important structures inside the brain, where we want the electrode to start, where we want it to end, making sure that we are exactly on our target. And essentially, our computer software is generating a custom-made frame that you can see here on the right side. So this device basically has 4 legs, as you can see, and each of the leg will eventually be attached to one of the marker that's located under the skin currently for the patient. Once the device is fixated, like you can see on the right side, then it guides the 2 electrodes, which are the green lines, on this woman illustration. And the 2 electrodes are guided exactly on the intended trajectory. So that custom-made device is only placed at the time of the surgery in the main operating room. And so we have a company basically that makes this custom-made system with a 3D printer. And so when it comes in, it's sterilized by the hospital and ready to be used in the OR. And so this is an illustration where, again, the important point to remember is that the patient's head is not fixated to the bed. And so for us, it doesn't change anything. But for the patient, it's critical because during the surgery, it allows for movement of your neck. And otherwise, with a large stereotactic frame, it's heavy on the head. And the position to the bed can be awkward. And so a lot of our patients used to have a huge amount of neck pain. So the head area, even though we work there, it's numb up completely and the patients don't feel anything. But a lot of discomfort is coming from the neck area. And so then the anesthesiologist has to use a lot of medication to correct for that neck pain. And then it slows down the progress, after the surgery. But essentially we made a small incision over the area and make a tiny opening in the skull exactly where it needs to go for the placement of the electrodes. And then the next step is we like to have the patient emerge from being in twilight, from anesthesia, so they can participate in a quick physical examination. Typically, Giselle is there to assist with the examination. And there, the electrodes are in place, and we're providing a little bit of this stimulation. And we're checking to see if the symptoms are indeed getting better, if we're targeting the right symptoms. and to make sure that there's no significant side effects from the stimulation. And that step is really to emphasize, what I mentioned, that we put a lot of effort for symptoms improvement to make sure that, after the therapy, our patients will experience a lot of benefit from the procedure. And during that step, it's very critical not to have the head fixated to the bed again, because you're, out of anesthesia, and we want to make sure that you're comfortable. So, with the head pillow and essentially not feeling any pain. At the end of this stage, the patients are admitted to the hospital, typically for 1 day, and all the system is internalized under the skin, and you have the 2 electrodes in place. And typically the tips are on the right side. But, like I said, if the patient is using the right arm a lot for sports, then we would go on the left. But essentially, the purpose of this slide is to show that the entire system is internalized under the skin, and so that there's no hardware that's visible from the outside. About 1 week after the surgery, the patient will return to the operating room for the final placement of the pulse generator. So that small battery, basically, that goes under the collarbone, as you can see here. And there's a connecting wire that goes behind the ear to reach the area of the pulse generator. A lot of patients ask me, how do you guys, insert? Do you make an incision all the way along? Is there any component that's visible on the outside? And so the answer is that we use this tunneler. So basically that creates a pathway under the skin. So there's no long incisions and there's no visible hardware on the outside. So we create a small track, so to speak, or pathway, and the wire are inserted that way. And then we connect the device to the electrodes. And then during the surgery, we test the system to make sure that all the connections are functional and that system is operational. At the time where you go to home after this procedure, you go home the same day and the device is off, so that you don't yet have therapy. And that's because we want to make sure that any swelling is resolved before we start the stimulation. We want to make sure that the wounds are healed up. So for the first 2 to 3 weeks, we're really focused just on healing from the surgery and making sure that you're back to your baseline before we introduce the stimulation. And here we have an example of what the stimulation looks like. Again, there's no poking, through the skin or anything that's attached to the body during the stimulation. And so the connections are usually using a Bluetooth connection between the device that's represented with the cone ray here on this illustration. So like a Bluetooth connection with our physician programmer tablet, like it could be an iPad or a Samsung tablet. And we have a representation of the electrodes, and then we shape the electrical current. It's represented here like a purple lemon. And so that's the electrical current that we can shape. And as I mentioned, with directional lead, we can skew it on one side versus the other. And at that time, we perform the same examination to see if your tremor is better, if the rigidity is getting better as well. From month to month, we make some adjustment. Once after 2 to 3 months, typically we reach optimal parameters that work for the patient. And after that, we can space out the programming episodes to the same frequency than you're currently seeing your neurologist in clinic. So just to finish in conclusion, the takeaway message from the talk is that DBS is really a good option for those patients who have a good response to the to Sinemet or L-Dopa, but are experiencing problem from the medication for a reason or another. And so it could be that there's too much off time, so that you're taking a medication and it works well, but it works well for a short period of time and then you're off again. You have to take another dose. Or alternatively, it could be that you're experiencing side effects with the medication. So you take a dose, you're doing well, but you're having a lot of dyskinesia, a lot of extra movements with the medication. And you would actually need a little bit more to control your Parkinson's disease, but you're limited because you're having those side effects. So the DBS is good. in that sense because first of all, it's a therapy that's continuously on in the background. So that helps with the off time. So you always have something that's there in the background to help you out. And once we initiate the DBS therapy, presumably we can reduce the amount of medication that you're getting in terms of the dosage and the frequency. Patients ask me usually, can I come off medication completely? In the case of Parkinson's disease, typically not. So, we are expecting patients to continue on medication, typically the same medications than they had prior to the surgery. But we're hoping that we can reduce the dosage and the frequency. And so, in the majority of cases, we can reduce maybe 20, 30% for the dosage and the frequency, and that can make a big difference. Another takeaway message is that DBS technology has improved incredibly in the last 5 years. And so it's actually a great time, right now for those patients undergoing the procedure in that essentially is safer now because it's MRI compatible. So in the past, people used to be limited in getting MRIs. And it's more efficient. So with that directionality on the leads, we can really focus and stimulate only the hot spots, so reducing any side effects or complications that you can have from the stimulation, and the device can last longer. So DBS therapy was already a safe, options for Parkinson's disease. I'd say that with the new technology, it's even safer now. And at Providence, what we can offer is that for our surgeries, we really with that frameless DBS system, we are focused on comfort during the surgery and after surgery with early mobilization. And we work with our allied partners in the hospital to really make sure that the patients can return to their life quickly after the procedure. So that concludes my talk, if there was any question.
Hi, Dr. Lonjavan. Thank you so much. That was really a great talk. I think we really learned a lot and gave our patients really a lot of more clearer picture of what deep brain stimulation is. That was very, very good. And like Dr. Lonjavan mentioned, there has been a lot of changes in DBS the last 5 years. There
Yeah, so
has
I'm
not
seeing a
been a lot of
question.
questions.
Yeah, I'm seeing a question
Here.
here, Giselle. It's a good question. And it's a question that we get a lot. How visible is the components, especially if you have a receding airline, for example, or if you're combing your hair, like are you limited into cosmetically, right? So like how visible is the device? And the answer to that is, we're both the device maker and us as surgeon, we're really focused on trying to minimize any aspect that would be visible. So there's a little locking mechanism. Everything is under the skin, first of all, so there's nothing visible like hardware or implant from the outside. Occasionally, you can see a profile, a little profile where the device is anchored on the device. And so what we do is we basically shape the skull so that the anchoring mechanism is flush, basically to the surface of the skull, such that when we close the skin, there's no profile that's visible. So the scar, a linear scar where the device is implanted would be visible. The scalp typically heals really well, so that it becomes pretty hard to see. But it's something that can be visible. The other thing is if you stretch your neck, you would see a little bit of the wire occasionally under the skin. And then on the chest, you would see a little bit the profile of the pulse generator. That said, so by implanting the wire a little bit deeper, in the skin, then it's less visible. And by using a rechargeable device, they're about half the width, the thickness of the prior systems. And so it honestly becomes pretty hard to see. And, we've had patients where, frankly, they come to see us about 2 to 3 weeks after the surgery for their follow-up appointment to make sure the wounds are healing well. And you've seen those patients with me, Giselle, in the clinic. It's actually hard, to even for us to see that they have a device that's implanted, even with a receding hairline, with no hair. And for women also, where like there's a lot of hair, but you need to go to the hairdresser. The fact that it's recessed and it's flush to the skull, it makes it such that nothing sticks. So if you need uh, the, to comb the hair or to shape it in any way, you don't really need to tell your hairdresser that there's an implant there. They won't feel a difference. And so there's no and first of all, there's no limitation in what you can use in terms of air product. I see another question on how long is DBS surgery effective? 3 to 5 years or more, 5 to 10 years. The short answer to that is DBS remains effective throughout the lifetime of the patient. Um, and what I mean by that is that let's say somebody has DBS surgery today and then they come to see me in clinic in 10, 15 years from now. Uh, they may be worse off in 15 years because unfortunately, as you know, the symptoms of Parkinson's disease will continue to progress in the background because DBS or medication currently is not stopping the progression of the condition. So the Parkinson's disease will progress. But at the same time as the symptoms are progressing, because the condition is progressing, we can make adjustment to the DBS by increasing the dosage of the stimulation to counteract the increase in the symptoms. Your neurologist will also make change to your medication to counteract that. And if we were to stop the DBS therapy in 10 years or 15 years, you would at that point be a lot worse off than with the DBS on. My point is that even though in 15 years from now, this condition unfortunately might be worse than what you have today, the DBS will still be alongside you to continue improving the symptoms. And that's true for essential tremor as well. So we have shown over and over that the DBS therapy does not lose its efficacy over time. From initial consultation to final recovery, how many weeks or months are required to be the completion? So from the surgery from start to finish, meaning from the implant of the fiducial, the markers in the clinic to the final implant of the device. So we have to plan about a span of about 3 weeks. So during that time, there's 1 day in the hospital. The rest of the time, it's outpatient with 3 procedures, basically. So it's spanning about 3 weeks. And from the time when you actually feel improvement from the DBS, I would say that you have to plan about 2 months from the time of the beginning, because after the 3 weeks when everything is in, we still wait roughly another 3 weeks before the device is started. So you won't really feel any improvement for about a couple months from the time we start. And from there, you still have to give yourself a little bit of time and be patient at the very beginning, because the programming takes a little bit of time. So it's like an old radio where you fine tune, the dial. And so you don't want to go too fast trying to correct all the symptoms quickly. So there's a little bit of fine adjustment. How many devices have been implanted to this date? Is it still a very rare operation? No, so it's a common operation. In Los Angeles, I would say there's probably roughly about, something in the orders of like 200 cases that are performed every year, just in the area here. Currently, there's approximately 200,000 people that have been implanted worldwide. The surgery is performed, anywhere in North America, obviously, in the industrialized country. The main limiting factor is the expenses related to the device. So, there needs to be an infrastructure where the medical payers are able to support it. So, fortunately in the US, Medicare is paying for it, and the private insurance companies are. And so Europe, Canada, and the US are the biggest implanters in the world, US being the leader. But it's approximately 200,000 people implanted since 1995. And currently the indications are increasing for DBS. So Medtronic added seizure disorder, for those people who suffer from epilepsy. And we are actively looking at 2 psychiatric applications for the future. And so we're expecting that the technology is going to be applied to a larger number of patients going forward. But it's not a rare operation. Is the operation covered by Medicare? Yes, unfortunately, Medicare is covering for the device. Medi-Cal is a different story that's harder, but Medicare, is a great payer for the DBS therapy. The cost out of pocket, so so that's a question that we get often. Unfortunately, it's a case-by-case basis. Anybody who is interested in the therapy, we can put them in touch with our assistant. They can work with your insurance company so that these questions can be all sorted out, beforehand, so that there is no surprise. For us on our hand, we're primarily focused, like I mentioned, to carry out a safe and efficient, procedure that you come out with great benefit. But for the most case, I haven't encountered a lot of patients where the out-of-pocket cost would be prohibitive. But out of more than that, I'm not aware.
There is one more question, Dr. J.
What future change do you see with DBS devices and gold? I think that where we're heading in the future is two things primarily. I think that essentially we're heading into a world where, like, the directional current that I showed, where like the shape of the current can be modified. I think this is going to continue to evolve, where the electrodes, instead of being broken down into 3 subunits, are going to have 15, 20, 50 different subunits, so that you can have even more complex shape. So I think that's something that's going to be coming up in the next several years. The engineering is there, but again, we're limited with what's feasible, like financially, in our society. But I think that we're heading into a direction where the current is going to be even more precise, where it's targeted to the brain. And the second area where it's going to go, it's to what we call artificial intelligence, where currently we have that biomarker that your provider will be able to follow from month to month if you have the Medtronic device. So they're going to be looking at the specific marker, whether or not you achieve a good response or not, and they can make change to your medication. They can make change to the DBS to optimize the treatment of that marker. And I think the next step to that is to close the loop, so to speak, where the device itself is going to automatically read that biomarker and automatically make adjustment to itself from a day-to-day activity, so that your device is continuously reading where you are, into your Parkinson's disease control. And it's going to optimize the programming parameters, and could even make suggestions to your provider as to like which medication could be considered to provide better coverage. So I think those two areas are going to be the main focus, and that's going to expand the use of DBS, because there's going to be a little bit less reliance on the provider and on the patient. So you're not going to have to go see your provider as often to have an adjustment, and the provider is going to have to do less work, so to speak, to adjust the device, because the computer is going to do it itself. And so currently that's where the investigators are working on. Other devices under development. Yeah, other device under development. Not that I'm aware on the DBS side. I know that there are some other countries like China that have their own device. A lot of them are by reverse engineering, copying what the US has done. Those 3 device makers currently are the leaders. There are other stimulation devices outside the brain that are being activated. And there are smaller companies that are working on niche adjustment, to the technology, but most likely they will be acquired eventually by the 3 main device. Does the surgery work well for those with Lewy body disease? Usually, we want to make sure that anybody who has a so-called mimicker of Parkinson's disease, it does not get DBS, because the results are not as good. And so that's where, like I said at the beginning, we prefer when patients have had Parkinson's disease at least for 2 to 3 years, so that everyone is comfortable with the actual diagnosis of Parkinson's disease. When we go outside of that, it really becomes a gray zone. So we prefer to focus on Parkinson's disease oftentimes with Lewy body, there could be other symptoms that are not going to be improved with the DBS, and everyone can be disappointed. So typically we avoid doing the surgery in that context. So I think we're at time.
Yeah. Thank you so much, Dr. Donjavan, for coming in and giving us a lot more information and clarity on deep brain stimulation. That was such a wonderful presentation. We really do appreciate your time. I know you're really busy today, but thank you so much for coming on and talking to us. Thank you so much for your questions, everyone. We do truly appreciate your questions. If you do want to listen back to the webinars, they're going to be live at they're going to be posted at our website at pacificmovement.org. Thank you very much. Have a great week and rest of the month, everyone. Take care.